Hello, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Bright Spots Ventures. We bring leaders together each episode to inform you, all of our listeners and viewers, but also we want to unearth bright spots or successes at these health plans that you see before you, hospitals, other healthcare-related organizations, because our goal each episode is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective way to improve healthcare in our lifetime. If you're new to the show, welcome. If you're new to our live video stream and webinar, welcome. If you've not subscribed to our podcast, this episode gets dropped a few days after we record it on Tuesdays. If you want to get a new episode with bright spots and ideas from leaders each and every Tuesday and go back in the archives and see all of the great ideas that we've cultivated from all of the great smart people in our industry, I encourage you to go to Bright Spots in Healthcare, wherever you listen to podcasts, and subscribe. Really appreciate it. The more people that subscribe and rate us, the more of your peers can find us, more folks could get this great information that we bring to you each and every episode. Our topic today is an important one. It's predictive analytics and proactive healthcare and how to leverage artificial intelligence to transform risk management and care management. We're super excited to have you all here to talk about it. I'm going to actually, as I get started here, I want to ask our live audience a question right off the bat. I want to ask them what the biggest challenges their organization faces using AI for predictive analytics. So we're going to start there. Our sponsor today is a really special organization born out of Stanford University called Prealize Health. If you haven't heard of them, they are a leading provider of AI-driven predictive analytics. I'm going to tell you a bit more about them later on during the episode, but if you want to check them out now, you can check them out at prealizehealth.com. We're also going to bypass bios, as we always do, because we don't have time for that. We're going to have a pretty tight schedule today, but we will post a link to our great illustrious panel, the bios to all four of them. You will see in the chat if you're watching live, and in the show notes if you're listening to the podcast. I will introduce them by name, title, and company. We have a great group. Bethany McClear, Chief Actuary and Chief Analytics Officer at Johns Hopkins Health Plan. Amin Sarahali, he's the Senior Vice President and Chief Data and Analytics Officer up at Independent Health in the 716. Shout out to the Buffalo folks. Mike Triash, he's the Senior Vice President and Chief Operating Officer at HAP out of Detroit. And Dean Noble-Tola, he is the Chief Product and Analytics Officer at Prealize Health. So welcome. Thank you all for being here. Really appreciate it. Yeah, Sherry, you could share those results to our live group. Maybe we could actually put the results in parentheses in the show notes too, as I'm looking at it, to that first question. Let's get started with you, Mike. And I want to talk about, as you know, foundationally, how your health plan has been investing in a unified data lake to drive that personalization and engagement that you need to do and want to take advantage of with AI. And can you walk us through an example of how this is helping you guys better connect with members?
Yeah, it's funny, Eric, your poll, I would have added a different category, and I would have added people. I think we have an abundance of data, and the technology right now is pretty straightforward. This is an organizational change and transformation issue, trying to get people to understand that we can use data to create a different experience in healthcare. And that, honest to God, I think that's the hardest part right now, because most people who have elevated titles, man, they don't have data on their resumes, and that's the dangerous zone to step into, to say, I'm going to be vulnerable and be creative. One of the things we are invested a lot in the last few years is predictive analytics, and really I call it advanced predictive analytics. Some people call it AI. I just say advanced predictive analytics. And what we see is being able to drive deeper insights in the customer experience than we ever have before. We are small health plan in Detroit, Michigan, but we have a large parent, and our parent organization is the Henry Ford Health System. And when you combine our two data sources, it's an immense amount of data that we have at our fingertips. And advanced analytics, what it likes is it likes a lot of variables. If you're doing traditional regression analysis, you're working with a handful of variables. In advanced analytics, you can source a lot of variables and find the 4 or 5 that really matter in combination to one another. Now, there's challenges. We have 9 terabytes of data. I'm not sure what our parent has, probably 4 or 5 times that. You make that data available to analysts, I'm telling you, they're still going to rely upon and use the data they're comfortable with and they know, because that's too much. There's too big of a space for them to operate. So a few things we've been doing to overcome this challenge is, one, we're creating a unified data lake between our 2 organizations. And that's the data that we believe is meaningful to the customer experience and the patient experience. As we do that, certain things we need to do to make that data more reliable, better quality data, so a lot of people have more trust in it. So we're investing heavily in master data management, data governance, data cataloging. Those are things such as making sure we have solid definitions, making sure the data is reliable. If we have to transform the data, we do this transformation so they're reliable across all analysts, across all organizations. And then as well, we're cataloging the data, because you imagine, you're talking about, 20, 30, 40 terabytes of data. The hardest part is knowing what data is out there. And once you know it's out there, then you can start governing it, mastering it, applying quality numbers to it to make it more, make people, more comfortable with the data they're using. So, question you'd ask is, why are we going through this? We just have this unique opportunity. We have this unique opportunity right now to drive better insights into the patient customer experience we've never had before, because all the things we just talked about, the data is there. The technology allows us to do things we haven't done in the past. Now, what we do is we really try to understand things such as digital propensity. So if you're a consumer out there and you are a high-end user of MyChart and you do e-health visits and you've authenticated with our app on the health plan side, I'm guessing you are pretty highly engaged digital consumer versus somebody who's done none of those things. So for us, where you have digital engagement, what we're exploring is opportunities to drive better consumer engagement, meaning impact access, impact outcomes such as HEDIS measures and other quality measures. The other question I want to study, I really want to know though, is if you are new to digital engagement. So if this is a game which is new to you, you've been given access to the tools, you've discovered what you can do. Are we really pushing the needle? Are we really improving outcomes? Are we really improving access? And I don't know, nobody's ever really studied that before. That will inform us, because one, is digital really the panache we think it is? Or maybe we need to learn how to engage you digitally differently. Detroit is an interesting case when you're talking about consumer analytics. We are a petri dish of diversity. We have a large African American population. We have a large Muslim population. We have a huge Chaldean population. Chaldeans are Christians from Iran and Iraq area. The diversity within our market is immense, and our opportunity to really study digital engagement in healthcare is it's an exciting opportunity for us.
Okay, that's a lot. I love that. Great way to start. I'm going to summarize some of what I just heard. And Mike, if you could just keep me honest here. So you needed a way to connect both the Henry Ford system, we'll say the provider part of the business, with HAP, the plan side, and create a unified data lake so that we could take the most important data that drives to enhance the customer experience and share it amongst the 2 organizations. And you're doing that. You had 3 kind of key components to executing that: a master data management program, a data governance program, and then an approach to data cataloging.
Yeah.
So far, so good.
Yep.
And then right now you've developed it. Tell me if this is through that initiative a digital propensity factor, or is that actually a data point that you're putting into that lake, or is the lake generating the propensity factor?
Yeah, so one thing we do, we create an architecture, we call it the Consumer 360. We also call it a golden record. And it's really, what are those data points that we have most mastered, most governed, and are most important to that customer experience?
Okay.
That allows us to reuse that structure and to really drive deep insights into that experience.
That's a whole. We're going to be really tight on time. I almost want to dive into that and how you come up with those data points, but I'm gonna refrain from going there with you, because I just want to make sure we stay on time. But there was something you said that was really important too, that throughout this whole thing, you're asking two really simple but pretty complex questions. Are we really improving access, and are we really improving the customer experience? And answering those questions will shift your strategy over the next 12, 36 months, right?
100%. 100%. And go back to your question on digital propensity. I really want to study those individuals who we are engaged digitally with versus those who we are not. And interesting part about digital propensity, it's contextual as well. There are certain things you may engage us digitally, certain things you may not. Even if you lead a digital life, there are certain complexities in healthcare. You just want to talk to a human being. And even if you're 80 or 85 and you got cancer going on, if you're just a digitally propensity or digitally oriented individual, there are just certain offerings we still should make to you. Or maybe you've got a 25-year-old grandchild or child out there working with you who is digitally oriented. So this is why it's really important for us to get to know those consumers. The digital propensity model we're building, really important for us to answer those other questions. Are we engaging you in the right channel that has a meaningful impact on your experience and a meaningful impact for us?
Love it. I love it. There's probably, I'm going to shout out to my producer, Sherry Kales. There's probably a whole episode on sort of like the Moneyball kind of concept of data points and what data points really matter to correlate the customer experience, and then getting to where you were going there on that digital propensity and how to kind of differentiate the folks who are digitally engaged and not digitally engaged. What does that really mean? I mean, that's a whole series. I love that topic. Really interesting. Speaking of which, and I'm going to move over to Bethany in a moment. We have a couple of episodes coming up right in line with this topic. So if folks want to join us next week, same time, 12 o'clock, we do all of our live shows Thursdays at 12 p.m. East Coast. We are going to cover the topic of how plans could evolve from segmentation to personalization. We have an incredible panel there. A Chief Operating Officer at Highmark Health, CIO at Cambia. And if you also want to join the following week, we've got the evolution of product design, and we've got another senior group. So if you want to come to those events without having to register, and we'll just register for you since you're on this show watching it live. For those of you who are watching this live, just click on the yes and we'll register for you. All right. Bethany McClear, like I said, is the Chief Actuary and Chief Analytics Officer at Johns Hopkins Health Plan. Bethany, how are you guys leveraging predictive analytics to proactively manage risk, and maybe share an example of where data-driven insights are leading to measurable improvements?
Great. Yeah. I mean, I could talk at length about this because my team is super immersed in this kind of thinking right now, but it goes along with, I think, the theme of what you just said and what Mike talked about of really moving from generalized strategies to precise strategies. Before I kind of get into it, I want to give just a short bit of background around how we identify and manage risk internally, and then focus my answer on our care management applications. So Johns Hopkins owns the ACG system, which is the world's leading population health analytics software. And now we at the health plan have been using it for years, but with more of a traditional risk score based approach. And with risk scores, you don't really get at the nuance of a risk profile. So do I have a population made up completely of members with well-managed chronic conditions? Or do I have a population of mostly healthy non-users plus a cohort of cancer patients? Those could very well give you the same risk score, but they're wildly different clinically. So about 18 months ago, we engaged with Alestra Health, which is a newly launched Johns Hopkins subsidiary that specializes in pop health solutions. And their solution built on the ACG using AI models to categorize members into actionable and clinically meaningful segments. So people are segmented based on complexity of need, incorporating things like social need indicators as well. And acknowledging that, the concept of pop health stratification really isn't new. The capabilities with this approach for us have been taking our organization in new directions. So not wanting to make this a Hopkins commercial here, the initial reason that we engaged with Alestra was because we wanted to evolve our care management model, but we didn't have the right insights to do that. We wanted to move from our disease-focused generalized strategy to something that was more whole person focused, specific, and targeted to drive higher impact solutions. So 2 areas we've seen value with this program out the gate. So one, using Illustra's impact focused algorithms to really identify who should be getting what interventions. And then 2, using the insights available from the patient segmentation to assign the right work to the right team. So who should be doing what interventions. So the new algorithms really now enable us to do that precise matching of members to the interventions and interveners that yield that high impact for them. So for example, members with behavioral health risk factors are now being identified earlier and routed to integrated behavioral health specialists instead of traditional case managers. Another example, we now differentiate between high complexity members and our rising risk members, completely different set of needs. So rising risk members, our goal is to stall or prevent their progression. Focus for the high complexity members is around achieving personal goals, but while also connecting them to the most effective providers and resources for them. So internal analytics side note, we internally now are able to create provider benchmarks by patient segment to highlight which provider groups really perform best for which patient population. So for example, we see a highly variable MLR experience across our providers for our highly complex and frail populations. But we also see that some of those provider systems that perform very well for those complex members may not be optimally suited for some of our lower complexity members. So that's the nuance. So these new capabilities have changed our intervention strategy, but also now we're directly driving our staffing model off of it. So the who, the what, the how many, and all of this really creates operational efficiency for us, reduces redundancies internally and with our provider partners.
Wow. So essentially, and if I could sum that up, I don't want to simplify it, but I just want to make sure we get it right for everyone listening. We're taking a predictive approach to really understanding the detailed complexities of an individual and making sure that we're getting them to the right care at the right point of time. I know that's a term we always use, but it allows that you guys to navigate folks to your own hospital system when it's going to provide a better outcome, or outside of your own system when it's not.
Exactly. And sometimes there's a tendency to want to put everybody in care management or make sure we're touching all the members all the time, but that's not the new kind of strategy is really being formed around which actions and who providing them really provides the most impact for the member based on what we now understand about who those members are and who those providers are.
Great. I want to bring in our Sarah Holly. He is the SVP and Chief Data and Analytics Officer at Independent Health. Another Chief Analytics Officer here. And I would love to talk about pragmatic applications and continue to do that and provide everyone examples. So, as plans are getting better and more effective with proactive outreach and identifying the members that need to be reached, I would love to get an example of how you are applying a proactive model to successfully drive a call to action for a patient and or a caregiver.
Well, thanks, Eric. Well, first of all, I think that Bethany has been spying on us. That's exactly what we're doing. Very, very similar approach. So we have been using for many years, we have been using risk factors. Lately, we have been using rising risk. And we've taken the whole population and segmenting the population to who needs what and when. So she talked about behavioral health. We're doing the same thing. Who are the people that need behavioral health right now? And what we learned is when somebody needs medical and behavior, we really need to tackle the behavioral issues first before we can get to the medical and so on. So to go a little further, what we do from a rising risk, we actually do a couple more things. We identify what are the top 3 to 5 conditions that are driving the risk to rise, and that's really gives us that specificity, what we need to do for this person. But also we have a different model. We have our case management, which is mostly telephonic, but then we have another program that we started a few years ago called Care for You. And basically, actually, we go to the patient's house. Actually, my family itself kind of benefited from the Care for You model. My father-in-law actually was going through cancer, and we saw, actually, I saw firsthand the good work that we do. So, and I want to use that to talk about something else, which is end of life. So on top of the the care management, case management, we actually started looking at end of life. And what we see, actually, we see a lot of people dying in the hospital. We see families that are very confused and the end of life. And if you ever went through that with your family or friends, it's a tough experience, especially if you're not prepared for it. So how can we get our members to be prepared for that end of life? So we're predicting the people that most likely, for example, to I know it's morbid, but we have to do it so we can help the people. Who are the people that are most likely to die within the next 12 months? How many of them have a MOLST or have advanced I'm sorry, oh my God, what's the word? Advanced directions. So how many of them have all this stuff? And can we even prepare them to what's gonna happen and explain to them what they can do and what they should be expecting? So that's really what we're trying to do. We started doing in our palliative program and really getting that education. These are tough discussions. You have to train your staff to be able to have those conversations, but we're seeing, honestly, it's people want to hear that information, want to learn. So that's an example I wanted to give you that we do very specific to educate people.
That's awesome. And do you have any sense of the results of that program?
Well, first of all, we're not looking at satisfaction yet. So we're trying to figure out how we're going to calculate the satisfaction from the patient or their family members. But really what we saw is we looked at the last 2 months of life, and we saw how many people died in the hospital. And we saw actually a huge decrease in people in the program that did not die in the hospital. We saw what is the average length of stay in hospice, and did people even go to hospice?
Right.
And I cannot remember the numbers about it. It's significant difference. We saw how many people had, for example, for people who had cancer, how many have chemotherapy in the last 30 days or had radiation oncology in the last 30 days. And the numbers were very significant. So the difference. So yes,
Different.
people who
So
were
you're
in the
saving total
program,
cost of care. You're saving probably quality of end of life.
yes.
And everything. Okay, that's
People
great.
are not being radiated to the last day of life,
Right.
basically. Yes, that's what we're seeing.
All right. I know we've kind of iced Dean Novoltola is the Chief Product Analytics Officer at Prealize Health. Let's get him in here. Dean, I know you guys have worked with multiple plans around all different initiatives around predictive analytics and leveraging AI. Can you talk a little bit? We haven't gotten into sort of just the overall use of predictive analytics in supporting the business for these health plans, and how maybe they can leverage predictive analytics, or how you are already doing it with health plans to improve underwriting accuracy and using AI driven risk predictions, and maybe walk us through a specific example of a health plan who's doing a really good job of that.
Yeah, happy to do that. And also, like, these are all topics near and dear to my heart about data quality, data incompleteness, as well as like moving beyond risk scores. It's really awesome to see that people are seeing like we have to get like a lot more advanced, and there are a lot of more nuanced capabilities out there now than we used to have. In fact, our large model that we use is used for both clinical predictions and risk in clinical settings, as well as underwriting, as you just alluded to. And so we worked with a large Blues plan that was trying to grow its mid-market business. So I'm talking about groups that are between like 150, 500 members in size. And they were kind of seeing that they were passing on a lot of business. They were only even providing quotes for something like half of the business. And so they wanted to improve that process. And part of the problem was that they were basically looking at historical averages of similar groups as a way to price new business. And it's hard because you don't know anything about these groups, right? And even groups they did bid on, sometimes the rates were too high, and those groups would move on because somebody else is going to underbid you. Or if you go the other direction, right, you price this too low, you have the different problem, right? And it's a sleeper problem too, because you don't really know if you've hit the right risk for that. And it might show up 18, 24 months from now when you have mature claims and you realize, oh, I underpriced a high risk group. And so what they did was they turned to this new class of AI models. They're called either transformer models or foundation models. And this is the kind of model that underlies ChatGPT and Claude and these other prominent models that we've all kind of seen. But the key difference here is that healthcare kind of needs a different version of that, because we're not trying to predict, words in a sentence or, images in a video. We're trying to predict like the next event in healthcare. And so we need a transformer model that has been taught to understand the timing and sequencing of events in healthcare to be able to say, okay, this is the next thing that's going to happen to this person. And so what they did, and I think there was even somebody had a question about back testing in the Q&A. To start with, this large Blues plan just said, look, let's see if we can improve our pricing on new business by 2%, but let's do it as a historical analysis where we already know the outcomes. And that's a pretty small margin, but it really matters when we're talking about margins in healthcare. I'm sure lots of the folks here can appreciate that. And so they tried our model, which we call Metis AI, and they found we didn't just hit the 2% benchmark, we hit 6%, right? And that ends up being millions of dollars in improved margin for them. And that resulted in them already quoting 20% more business in the first 3 months that we've rolled this out.
Wow.
And I want to talk a little about how it's possible. If we have the time, Eric, you tell me.
Yeah. Well, I was going to ask you a follow-up about the transformer models. Is that where you're going?
That's where I was going. Yeah, you got it.
Let's do it.
Yeah. So historically, models have focused on risk episodes in healthcare, right? It's like, there's an ED risk. This person's in a risk bin because of other conditions they have. They could be by diagnostic categories, et cetera. And the trouble with that kind of approach is that it doesn't account for order. Now, it is effective to a point, right? You can probably explain 15, 25% of the risk in a population, but it's limiting. Like somebody who shows up in the emergency department for a diabetic or a cardiac event, and maybe that's the thing that says to them, hey, I need to start improving my health. And let's say they start exercising, they start eating better, and they actually do improve their health, and they go see their PCP, and it turns out they have a better blood pressure, they have a lower weight, et cetera. That person's clearly decreasing in risk, right? But in historical models that don't account for the ordering of events, somebody goes the exact opposite direction where they're escalating in their biomarkers, and they end up in the ED looks exactly the same. And so what you need to do is you need something like this new category of models. Transform models actually excel at understanding timing and sequencing. And that's why they're able to pick out trends that are otherwise just impossible. And to Mike's point earlier, like, the scale of the data is enormous. And these kind of models, you can literally just feed everything in there. And then it will tell you, yeah, this is useful for predicting that particular outcome you care about.
Great. Listen, you just teamed me up really nicely. So I had asked when Dean and I were going to get into the weeds on this topic in preparation for the show, and we were talking a lot about this transformer model and time to event and sequencing. I asked him to have his team just create a quick little, I don't know, cheat sheet or summary for me. So we have a PDF that he created for us that is about 3 or 4 pages that talks about leveraging AI to unlock time to event intelligence. So if you want a copy of that, we'll send that out to you guys right after the show. No registration or anything like that. Just click yes. Sherry and I will shoot that out to you guys, and you'll have it. It's a quick read. It's a 2-minute, 3-minute read, but it's a good cheat sheet for everything around this transformer model and sort of the baseline to everything that Justine spoke to. I'm going to bring back Amin Sarhali again, SVP and Chief Analytics Officer at Independent Health up in Western New York. I mean, I love you gave us a really good example of how you guys are applying AI and predictive analytics towards end of life to improve quality and total cost. What about around chronic disease management?
Yes, we honestly do a lot for diabetes, CHF, CKD, for example, for diabetes. First of all, we try to identify people who are pre-diabetic and who are the people that are more likely to become diabetic within the next year, the next 2 years. And we try to, kind of reach out to them, reach out to their doctors, and help them nudge them so they can lose weight, take their medication, and so on. So, and we honestly seen that we slowed down the progression of people from prediabetes to diabetes. Actually, it was a corporate scorecard for us that we were really working on at the highest level of the company. We wanted to reduce that progression of disease. Right now, we're working on CKD, chronic kidney disease. Chronic kidney disease, what we have seen from our data that, for example, these are some scary numbers. About 55% of our members, when they first have dialysis, they have it in an inpatient setting. So we call them crashes. They crash. They didn't even know that they have CKD. About 50% of that population, when they have a dialysis, have even seen a nephrologist? No, they have not seen a nephrologist to begin with. The people who have a mature fistula, not even 30% before they have first dialysis. So really this screams of a couple of things. It screams that we're not really treating people with CKD, at least in our community, as well, that they need to be treated. But honestly, I think this is a national problem. This is not just to Western New York. So what are we trying to do? We identify a couple issues. First of all is that providers are not even coding CKD1 and CKD2. Honestly, I can speak for Dale about this, but when you get to CKD 3, there's stages to CKD. When you get to stage 3B, what we call that a point of no return. We know if you get to 3B, you're gonna go to stage 4, you're gonna go to dialysis.
So if we have 3A, we could get them at 3A, we have hope.
If you can get them 3A, you can revert even the disease. It will never progress, and even you can get it to never progress, you can even to revert. So how can we now? So what we do, we run models to identify people that are more likely that have CKD 1, 2, or 3, and we reach out to the providers to say, hey, we need you to confirm this diagnosis, and if we're finding that's the issue, yes, it is true. Then if you're, for example, at 3, we're gonna get you with a nephrologist. If 1 and 2, okay, we want to make sure you're managing your blood pressure first, you're managing your LDL, your A1C, and all that. So really what we're trying to do now is slow down that progression, identify the people like we did for diabetes, and we're successful in diabetes. We're trying now to do the same thing for CKD. And we want to really, for our community, slow down the progression of CKD. And so we have less dialysis and less complications in life.
So what you're trying to do is almost diagnose members who don't even know they have CKD before they have it, and or their doctors may know how it's progressing, and engage both of them to take action earlier.
And get them the right treatment, yes. Now, here's something that we found actually. We found that it takes about, I can't remember exactly the number, it's 94, something like that, but I know it's over 90%. So of the people who identified, 90% actually were diagnosed later, between 6 months and a year. So we're just identifying them at least 6 months early. But for somebody who's a 3A, identifying 6 months, that's really huge.
Yep.
Yeah.
Yeah, it strikes me too, like, being able to navigate and get folks engaged, it's so critical, and there's such an easy use and incorporation of AI. And I know I'm going to bring back in Mike. Mike Triash is the SVP and COO at HAP. Mike, you guys are using AI to transform the interactions between your nurses in your call centers and your members. Can you talk a little bit about how you are using it to not only improve the customer experience, which you were referencing earlier, but also what you're seeing as it relates to cost reduction, and just how it's helping you create a better experience and get folks to where they need to go within the confines of their benefit design?
Yeah, and on this one, I don't think we're unique, and I think we're all doing something similar to figuring out how we can use generative AI in things like the call center, or when our nurses interact with customers. The biggest opportunity that I think all of us are chasing right now is just trying to generate original content off of all that documentation those poor folks have to search when they get a call. I mean, my call center reps have a library probably in excess of 500 different documents. Some of them could be 120 pages long. And what they have to do is search those documents plus desk level procedures and alerts to try to help formulate, the right answer. And sometimes I wonder how they ever get it right, which is just, phenomenal. You take our nurses, same perspective. So what we've been doing this for a couple of years now, and really some first generation tools, is just putting a generative AI tool in front of that documentation, developing a response which they can either choose to use or create their own. We've implemented some tools recently, which I call, next generation, and it's absolutely amazing within 18, 20 months how less code intensive these tools are, meaning less IT support, and how more accurate they are in their responses. And for us, we spend about 2 minutes and 8 seconds on every call trying to research our repository. We get that down to about 6 seconds now. That's just absolutely phenomenal. So where are we going, after this? And again, this is really nothing unique and innovative. And we're all kind of doing this. We're all learning in this journey. Next for us is we spend about 4 minutes documenting a call. So big opportunity for us. And this would, be basically every single call we take. We could reduce the call by 4 minutes if we could use AI then to actually document that call in our call record. And my folks aren't doing this on the keypad where they're trying to interact with you, and they're not putting you on hold when they're looking up a document or trying to do documentation. That really is going to change the experience, because now I can reward our reps for more soft skills around how they recognize what's going on the call, how they interact with those consumers versus their technical abilities to be able to get the right information and document the right information. The opportunities, you can go on and on using generative AI to actually do call audits. It's kind of the next area we're headed. Eventually, and I think we're all kind of doing this, is we're exploring what the hot term of the year right now is the agentic layer. How do we create super agents and utility agents in an architecture where they work together? And for us, ultimately, is having that virtual agent, which my call center reps can work with. And I keep saying, we're not going to replace your jobs, but if you don't, embrace the technology, somebody who does will take your job. And so, again, I'll go back where I started. It's the people part of this. The technology is easy. Yeah. We will get there. The people piece of it now is the hardest part of it I have. We will get there, and the opportunity for them to enjoy their jobs better, feel more accomplished, and create a different customer experience is just something I hope they get as excited about as I am right now, because we will get there and it will change the customer experience.
Yeah. I want to shift gears a little bit and go to condition management, and also talk about predicting and understanding patient behavior, member behavior. I know we're a little bit behind on time, so I'm going to jump around a little bit as far as my guests and panelists should know. First, I do want to let everyone know, if you've been listening to the show we've been doing it over 11 years, we can't bring you this great content and these great guests without the great partnerships and collaborations we have with our sponsors, our solution providers, who are providing cool, interesting ideas and solutions and technology bright spots into the industry. And I wanted to give some props to our partner today, Prealize Health. They are a leading provider of AI-driven predictive analytics that they provide to health plans, specialty care management companies, healthcare technology companies, employers, and providers across the land. They're committing to transforming healthcare from reactive to proactive, reducing healthcare costs and enabling more people to live healthier lives. Perfect sponsor for today's episode. And they are positively impacting the health trajectory of millions of people. If you want to check them out, prealizehealth.com. I want to bring in Dean Tola next. Again, he runs product and analytics for Prealize. Dean, proactive condition management. Tell me how this has demonstrated significant cost savings, and maybe provide an example of a health plan that's implementing condition management as an overall strategy, and just let us understand some of the key components that allow them to proactively do that outreach.
Yeah, I'd like to talk about a large regional plan in the Southeast. So what they wanted to do and what they're able to do with our predictions is look for three basic things. And some of the folks, we've already kind of touched on this because I hear some common themes here. It's who's rising in risk, who will actually engage with the outreach, and who can you do something about that's actually impactable. Like those are the three things that we look at, and you can have many approaches to how you identify those things. And the Venn diagram of those three things, the people in the middle of that are the people that are then surfaced to their care management team, and they get us like a member level summarized action plan of all of the insights that we have about them, both predictive and historical, to operationalize. And this requires you have to pull in lots of historical data, you have to train models, so you need medical claims, you need drug claims, lab data if possible, even EHR data, and then you need outreach data, like the history of who has been outreached to in this population and has actually engaged with it, preferably by channel, to Mike's point earlier. Now, what they found is that ends up being about 2% of the population that kind of fits all those requirements for this like very high touch care management outreach approach. And then, you're not going to get to all of them. Maybe you get to like 40, 50% of them actually will engage with that. And then you can do an observational cohort study retrospectively, right? You can find the people that actually engage with the outreach, engage with care management, or tied into programs. And you can compare them to other people who are risk stratified to be similar as a control group. And when they looked at that, what they saw was on average across all lines of business. So this is commercial, Medicare, Medicaid, $564 PMPM reduction in cost. So avoided medical spend that didn't happen. And so if we think about like a 500,000 member population, that ends up being about $13.5 million over the course of the year. Right? And I do want to, sorry, go ahead, Eric.
No, sorry, I was just doing the math. So that's just about $6,700 per year per member. And when you're taking that subset of the population, how much will engage? Yeah, you're getting to $13.3 million in avoided medical spend.
And I just want to emphasize, because it's a common theme here too, like you have to integrate that stuff directly into the existing workflow. Like we work with them to embed this into their care management platform. If people have to go somewhere else, if they have to access 5 different views to get the information they want, do that document search like Mike was talking about, that is not effective. And it slows down everything. And you also have to have training to talk about these are predictions. And you need to understand that the person you're talking to may or may not even be aware of this condition that you're about to have a conversation about.
Yeah, it's great. I want to bring back Bethany. Hey, Bethany, how is Johns Hopkins using predictive analytics to uncover the reasons, the why behind a patient's behavior, particularly when it comes to something, let's say, med adherence? Like, how do you know why Eric is not taking his meds?
So I love this question generally around the sort of behavioral why. And I think to kick off, I think eventually, once we have all the data of all the things, and there's lots of data out there, but we still don't know a lot about who people are, what they're doing, and those kinds of things. And so we have this modeling and we're getting more into it and it's giving us insights, but there's still missing information. And so a big thing that we've been doing is with the data that we do have, building more of these models, but we're still seeing so much value internally with sort of our human analytics team interaction with the model results. And so it's taking what the model does and digging into curiosities and saying, where does that lead us? Partnering with other parts of the business to see like, okay, here's what's happening. So as an example, this past year, our organization invested in a new initiative with a vendor partner on member outreach for med adherence. So we wanted to reach out to members to make sure they're filling their scripts. Our actuarial team created a, kind of wraparound, but prediction model to say, to support this around who's most likely at any point in the year, who's most likely to be non-adherent. So this allows us to really prioritize who should be submitted when, first, second, third, et cetera. So that kind of creates that aspect of informing the strategy. But so we also developed a monitoring model. So this was important for us to understand how our outreach was working through the year. And because we had a new strategy this year, we knew that like the projection model we had last year, the seasonality patterns, those weren't going to be predictive for us. So the team really needed to more more deeply understand the various sort of member journey lines, right? Like you fill a script, like what are the possible things that can happen? What are the probabilities of those? So they created this complex decision tree model. And fundamentally, what that gets for us internally is an answer to the question of, is our current outreach strategy going to get us to our goal, or do we need to pivot or supplement in some way? And there's such a small margin of error on these measures. So sometimes these critical insights into the why and what's happening can really be the difference between a 3, 4, or 5-star performance. So back to your actual question. Through that model building process, the team spent a lot of time exploring details, better understanding what was happening, why, and with that, some kind of different angles like emerge. So one example, which is maybe a common sense insight, is that scripts with higher day supply, scripts that are mail order, are both drivers of high adherence. But to supplement that member outreach strategy, then we can identify the providers who have prescribing patterns associated with lower adherence and add that to our provider strategy to kind of bolster the overall approach. Another example, a smaller thing, but that was happening, is some members who were popping up as non-adherent actually were adhering to their doctor's orders, but the scripts weren't being updated. So in other words, a member may have been told to take half a pill and only refill every other month. So they appeared non-adherent when they actually were. So to the degree this is happening more than like on a onesie twosie basis, a member outreach strategy, right, isn't really your most efficient approach. Needed to pivot and kind of take a provider angle to that. So we're still finding that a lot of these insights on the why and some of those things that we're identifying through our interaction with the modeling is adding more to kind of even the initial intent of the predictive model, helping us create more of like a cohesive, efficient overall strategy for the measure.
Great. That's great. See, so maybe it wasn't my fault. I was doing what I was doing. I was taking my medication. I'm going to jump around a little bit, folks. Just trying to get everything in. I know we're not going to get to every question here. So I'm going to put Mike, you're on deck here. I want to bring back in Dean real fast to talk about the blueprint. So we're talking, if there's plans listening and they want to enhance or build a proactive strategy here, right? Do things that Bethany just mentioned, do things from the example of that regional health plan in the Southeast that you mentioned just earlier. What are some of the key components in a blueprint that they need to figure out? Can we just list those out?
Yeah. I think there's kind of like 4 large pieces to that. The first is know your risks up front. And this could be for Medicare populations, Medicaid populations. Like you don't have to wait for claims data. There are capabilities out there to let you know the risks in those populations when new members come on. Or if it's an underwritten line of business, then it's more of a pricing optimization strategy, really getting the Goldilocks zone of not pricing too high or pricing too low. And then once you have that information, the next step is, and we've heard a lot of iterations of this, like identify the members who are at risk, make meaningful clinical predictions about them to prioritize, customize the way that you engage, outreach, and manage that population. And then you need to integrate all that in a meaningful way into your existing workflows. It can't just be some extra tool that sits off here on the side. It needs to be the lifeblood of the organization. And then lastly, like measure what matters, right? Like monitor, report, and pull all together the data all in one location.
Okay, I got to summarize that. That was great. Measure What Matters is a great book, by the way, John Doerr. So first, it's about risk mitigation, understanding which, you don't want to go too low, too high. You used the word Goldilocks. Truth be told, when we were prepping, I came up with that term. You just stole it. The Goldilocks risk mitigation, number 1. Second is identify and prioritize and customize. 3 is make sure you have a plan to fit into the workflow. And then 4,
you have to integrate
into the workflow, right? And then 4, measure what matters in the data and reporting. Super. Okay.
And if you haven't read the book, you should go read it.
Yes, I agree. I agree with that. In fact, I really have to reread it, to be honest with you. It's been a few years since I read it. Fantastic. Love that. Thanks, Dean. I want to shift back to sort of let's talk about those 4 things now, and what strategies, Mike, have you guys been able to leverage, especially in taking a proactive approach, let's say, to quality and member satisfaction?
Yeah, so where we've approached this is we have different Scrum teams and or domain. I call them domain-driven Scrum teams. Like one of our Scrum team is just customer experience, and what they do is they socialize their use cases, and then that Scrum team will go out. They go out and grab the data. They do the governance processes. They do the master data management processes around that, so that we can build that data model. An example is this is a non-clinical example. This is actually how you can impact admin cost is we're really focused on those individuals who have not signed up for a digital EOB. And so, you know what I'm talking about? This is that awful document us health insurers send you that you just throw in the trash can. It's regulatory required, and it tells you all the things we did to pay or not pay your bill. I can present that much better digitally for everyone. So we actively try to get people to sign up for a digital EOB. We spend north of $6 million in print and postage. And my ask is, man, if we could redirect that to care, that would be such a better story. I can predict right now. I know exactly. With high confidence, I can predict who's going to sign up for digital EOB. It's driven by age, it's driven by zip code, it's driven by tenure, and a couple of other variables. That's a good example how we use predictive analytics. I can monetize that now. I can monetize every interaction. I can monetize every campaign that we do because I know exactly what it cost us to send out paper EOBs. We're doing the same thing then for gaps in HEDIS, gaps in pop health, gaps in net promoter score. You know, some of these are hard measures. Some of them you're going to put a number up there. My goal then is to be able to present this to our technology, to our folks in the customer service center. So give them an opportunity to close these gaps. So that's how we monetize this. Good stuff.
Good stuff. I want to get to talking about bias. Before we do that, I want to bring Bethany back. Bethany, could you talk about, because one of the examples you gave this great example around understanding sort of medication adherence and prescribing. How are you using sort of a similar model to prepare for the organization around, let's say, policy changes? So, for instance, the IRA, like how did you guys use predictive analytics to help the organization be better positioned for the Inflation Reduction Act? Actually, before you ask that, because I'm going to get yelled at by my team, I have to remind everyone that we already in your inbox is a link to our feedback form, our survey. It's a 2 to 2.5 minute multiple choice survey. We use it to choose our topics to make ourselves better. And you could also get a copy of my own notes for this show, my unabridged notes for this show. If you do us the favor, just giving us 2.5 minutes of feedback, and then we'll send you out the notes as a thank you. That's in your inbox right now. So Bethany, how are you using these models to prepare for policy changes?
Yes, extremely relevant for us. Medicare products moving into 2025, major changes in Part D benefits. We adjusted our benefits materially, and internally we knew that most of our members would benefit from the changes, but we weren't sure that our members would know that, since we had also introduced a deductible for the first time. But also not all of our members were going to benefit financially. And so we were struggling a little bit internally with how to communicate to our members in an effective way, given that we weren't super confident exactly who's going to fall into which bucket. We were really worried about sending the wrong message to some members. So the last thing we wanted to do is tell someone good news, your drug costs are going to go down next year, and then have them actually see an increase. But at the same time, we didn't want to send something out there that was so generic that members were still left confused about how that change would impact them. So I see a lot of what we talked about today too, is a lot of conversations around AI is focused on better predicting outcomes, but these models can also be incredibly powerful just to characterize large amounts of complex data in targeted ways. So my team did sort of an advanced modeling technique called clustering that categorizes members into sort of like groups that are meaningfully different from each other. And so with this, we were able to sort of get 8 different clusters of members that roughly just tells you 8 different stories about what that member experience was going to look like between 2024 and 2025. And so at the end of the day, we were able to better understand who's going to go where, what would cause you to move from one group to another. We were able to interact with our internal communications and leadership groups to talk strategically about how this could shape our messaging, what to tell members so they could better understand which causes what outcomes. And so at the end of the day, the analytics approach really allowed us to outreach to all of our members versus some of our initial thinking around only reaching out to members who were most adversely impacted, but it didn't dilute the message. So that was a really big success for us internally this past year.
That's cool. Really cool. I know, and I don't want to shortchange this. Well, I am going to shortchange it. It should be a whole topic, but I do think we got to address how these models could potentially increase the chasm between the served and the underserved, and all kinds of biases that we have ourselves that we incorporate into these models. So I want to bring back in Amin, who is actually an adjunct professor at University of Buffalo, who teaches about this topic, about what strategies can we implement to ensure fairness and accuracy in these models. And so, I mean, I know we only have a few minutes here, but can you just at a high level share like the outline of what you would put in place to ensure that you're mitigating biases and these models are making a real big difference and improvement in how we do things?
I'll speak fast. So honestly, the hardest part is getting the data right. So for example, you want to check how the model is performing by race. Well, you need to collect race information and it needs to be accurate. It's not an easy thing to do. There are things honestly that we cannot control for. For example, veteran status was added as a protected feature in 1974. Genetic information got added in 2008. None of us had that information. To even if we want to check bias of our models against veterans, if you don't have the information, you're not going to be able to do it. I emphasize here, you got to get the data, you got to get the data right. It seems simple, but honestly, that's really from my experience, that was the hardest part. After that, honestly, I think things get easy. You have to understand that there's no single fairness measure that's going to provide you a complete picture. It's a fairness assessment. Honestly, it's a multifaceted problem that you have to take a look at. You have to understand that there's definitely going to be a trade-off between fairness and accuracy. And our approach, independent health, is we are grouping fairness measures into 3 groups. So usually, I think the industry looks at 2 groups. We look at 3 groups: fairness by representation, and basically we want to ensure that all the training data is representative of all groups, not just the target variable, but some of the predictors as well. So we want to see is this a distribution, kind of uniform between all the different groups, or not uniform, sorry, stratified. When we look at it from a stratified lens, are we keeping the same distribution of the population for a target group or any other predictor? We look at fairness by error. And for example, there, we want to see that, for example, the false positives or false negatives, false negative is the same. For example, we're predicting heart attack, but the false negative is high for women. Well, it means that women are not going to get the treatment they need. So we cannot have that. So in this fairness by outcome, we want to make sure that the outcomes are equitable, across groups. Now, under each of these, type of measures, there's a list of measures. So, for example, under fairness by representation, you can use demographic parity, you can use equal representation, you can use proportional representation, and so on. I'm sorry, I'm turning this to my class. Under fairness by error, there's equalized odds, treatment equality, all that stuff. But you have to use multiple, because like I said, no one measure is going to tell you everything. And each one, honestly, may find something that you may want to take a look at. And once you find the errors, then you can then use statistical techniques like oversampling, thresholding, recalibration, and so on to kind of fix the issue. Sorry,
No, it's great. I'm sorry I kind of sandwiched you there at the end. Listen, thank you, the 4 of you, for all your prep work and doing this. To everyone listening and watching, thank you for tuning in. We do not take the time you spend with us for granted. We hope we use the ideas, the examples, the bright spots shared today to inspire your thinking and enhance your organization's current approach to improving healthcare for all of us. We produce this show for all of you. And remember, this is your Bright Spots in Healthcare podcast. Take care, everyone.